it's an honor and privilege to introduce our friend and colleague from Spain, Professor and Chairman of the department, Javier Gavilàn, who's at La Paz University in Madrid, Spain. He has been there since 1977 and has published many books and articles in the world of head and neck cancer, otology, and skull-base surgery. So thank you for giving us a talk today.
Thank you very much to all of you. I mean, it's a real pleasure for me to be here in one of the most important places in the history of otology of all times. And my only regret is not being able to be there in person, but I feel like being with all of you. And over the last minutes, we will deal with a lecture that I call From Hearing Aid to ABI, a World of Options. This is part of an instruction course we give at the American Academy of Otolaryngology, and we give it along with my colleague Luis La Saleta, with Mario Cernotti. Professor Cernotti, as you probably all know, he works in Argentina, and with Dr. Erika de Celis from Mexico. Before starting, I would like just to take you to my hospital. My hospital is La Paz, as Dr. Slattery mentioned. La Paz is, it was at least the flagship of the Spanish health system. It was, as you can see in the picture, it was a very nice, tall, clean, round building. But as you can tell for the cars here, this is an old picture. And right now, La Paz is still round, but it's no longer tall, it's no longer clean, it's no longer new. It's a very small building now by the 4 big towers that they built in the north part of Madrid, and that constitute now one of the main points for the skyline of Madrid. Well, the good part of the story is that you can tell anywhere in Madrid where La Paz is just by looking at the 4 towers, and at the north end of the 4 towers, you are all invited to visit us anytime you want. You will be more than welcome. Well, these are my disclosures. We don't have any conflict of interest in relation to this presentation. And the learning objectives, these 3 basic points that you can see in the slide, basically what I would be happy to reach today is to give you a better idea of what can we do to solve the problem of a patient with a hearing loss. Why do we need to know something about how to treat patients with hearing loss? Well, let me tell you my reason for a lecture like this one. When I started in ENT in January 1980, that is more than 40 years ago, for patients with hearing problems, we only had 3 solutions. We had hearing aids, we had stapes surgery, and we had surgery for chronic ear disease, period. That was all in 1980. 10 years later, we started to see the appearance in clinical practice, because this was developing in research laboratories as the one you have there. But we started to see in clinical practice the cochlear implant. You can see by this picture the kind of incision we did at that time, huge incisions. That was the first cochlear implant we used in the 90s. That was the inner aid. That was a percutaneous cochlear implant with 6 electrodes, with 6 big balls. And when I mean big balls, it's real big balls that were inserted into the cochlea. And since 1990, it happened like an explosion of devices and solutions for hearing loss. The fact is that, remember I told you in 1980 we had 3 things. It was very easy to see a patient with a hearing loss, with a hearing problem. But in 2022, every time I face a patient with a hearing loss, I feel myself like trying to solve the Rubik's Cube and make a best approach for every single patient. Right now, we have, apart from hearing aids and conventional surgery, we have bone conduction devices, we have middle ear implants, we have cochlear implants, and we have auditory brainstem implants, ABIs. And the most important thing about all these options that we have is that the indications for each one of them overlap one to the other. So it's not easy to find sometimes what's the best approach for every single patient. And this is what I want to do this morning there, trying to clarify, trying to show you the way we manage hearing loss in 2022. The first thing I want to state, especially for the young people in the audience, is that auditory implants are not alternatives to conventional surgery or hearing aids. What I mean is we still have conventional surgery, we still have hearing aids, but in difference to 1980, right now we have much more things that can help us solve the problem. And again, we have the stapedectomy, we have the tympanoplasty, we have fancy hearing aids nowadays, which are much better than the ones we had 40 years ago. But we also have a lot of different things. So let's move from the list I mentioned before. We start by the bone conduction devices, then we move to the middle ear implant, then we move to the cochlear implants, and then we move to the ABIs, because this is more or less the indication rank if you follow the audiogram. We go from the easiest cases with conductive hearing loss to the most difficult cases with no nerve, no cochlear nerve, or no cochlea, where you cannot even put a cochlear implant. So let's start by conduction, bone conduction devices. Bone conduction devices may be surgical or non-surgical. I know you all know the glasses that we had before, the bands we have recently, but there are some new comings in this field of bone conduction devices that are non-surgical adhesive bone conduction devices. Basically, right now we can use adhere and the contact forte that you see here. These two systems are, again, non-surgical, but we also have surgically implanted bone conduction devices. And these bone conduction devices, first of all, you may hear when someone talks about these devices, you can hear the term osseointegrated implants. Not all bone conduction devices require osseointegration. Some of them require osseointegration, some of them do not require, even though they may get osseointegrated, but it is not the same bone conduction as osseointegrated. Okay, so how do we classify bone conduction devices? There are two main groups. One are the percutaneous devices, and the others are the transcutaneous devices. I don't know if for you per and trans means something, but the way to remember is that percutaneous devices perforate the skin. So there's no intact skin. There's something coming and going to the bone through the skin of the skull. Whereas for transcutaneous devices, we have a transmission through an intact skin. Percutaneous devices are very well known. They were the first to appear in the world of hearing solutions. And the most, the two that we have right now, the most popular are Baja and Ponto. Now, transcutaneous devices, intact skin, remember, can be passive or active. In passive devices, the sound processor is the one that generates the stimulation. Let me tell you something. For a bone conduction implant to be useful, according to the physics, you need a part of this device to be big. The device must have a big part, and then it may have other parts. When the big part is the one that goes outside, is the sound processor, then you have a passive system. It's called passive because it transmits the sound through the skin and needs a magnet, a strong magnet, to connect the internal part with the external part, because the external part is heavy. In the active systems, is the implant, the thing that we put inside, the one which is big. and this also has advantages and disadvantages. The main advantage is that the transmission is made directly to the bone. There's no power lost in between the skin and the bone. But the disadvantage is that the big part goes inside, and sometimes we do not have too much space inside. So these things must be considered. Now, passive systems are basically phono and Baja tract. Those systems have a sound processor, which is big, and we insert something inside connected with a magnet. But the problem with these devices right now is the same problem we had in the 90s. Probably some of you are familiar with the Odeon. The Odeon was a passive transcutaneous device that we used in the 90s, and it was, from an audiological standpoint, it was very good. The problem is that the magnet need to be so strong that the skin was necrosed, and it was discontinued because patients couldn't have the device for long periods of time because the skin had very serious problems. And on a lesser degree, we have the same problem with the passive devices that we still use in 2022. Now, concerning the active devices, we have basically two of them, which are OSIA 2 and bone bridge. And those are the ones that we have experienced. And again, these systems, the big part goes inside, vibrates directly to the bone where they are anchored. Now, when can we use bone conduction devices? Well, we use them for adults and for children older than 5 years of age. And this is just a regulation concern. The FDA or the CE mark, they accept these devices for children over 5 years of age, of these surgically implanted devices, not the adhesive. Some surgeons, for example, Professor Cernotti in Argentina is using the device in children younger than 5 years of age, as long as they have enough bone to put the device. But according to the regulations, it's adults and children of 5 years or more. Now, the main indication for these devices is the bone conduction threshold of the patient. And as you can see in this slide, if the patient has a very good bone conduction, that's a purely conductive with a bone conduction over 20, 25 at the most dBs, then you can use an adhesive like Adhere or Contact Forte. When the patient bone conduction is a little bit lower, then you can move to active transcutaneous like the bone bridge or the OSIA. And if you're facing a mixed hearing loss with a bone conduction, which is a little bit lower than 50 dBs, then the active transcutaneous are not useful. And you need to move to the more powerful percutaneous like the Baja Superpower. When we find this patient, these situations, this hearing loss, we found them in malformations, in otosclerosis, in chronic ear diseases, and in radical cavities. The main indications for bone conduction devices in our practice are malformations and open cavities and radical cavities. And there's one more indication that you probably are aware of, and it's the single-sided deafness. In the single-sided deafness, if you treat the patient and you want to use a bone conduction device, you need to have a contralateral bone conduction threshold, which is absolutely normal. Otherwise, the sound will not be able to travel across the skull and give a good hearing to the patient. And right now, end of 2022, the use of bone conduction devices for single-sided deafness is not the most popular tool to solve the problem. Right now, patients and surgeons, we prefer to use cochlear implants, and we will discuss the use of cochlear implants in single-sided deafness when we move to the topic of cochlear implants. But remember, if you if the patient wants to get rid of the head shadow effect, then a bone conduction device may be an option. One of the questions that come always to the discussion when we talk about bone conduction devices is whether we should use them unilaterally or bilaterally. There are people who are very in favor of bilateral bone conduction devices. The truth is that in our practice at La Paz, we seldom use bilateral bone conduction devices because, as you probably know, the attenuation from one side to the other through the bone with the bone conduction device is about 5 dBs. So the hearing with one single bone conduction device is affecting, is going to both ears. So for some situations, you may use bilateral bone conduction devices, but in our practice, we mainly use unilateral bone conduction devices. Now, let me make a brief overview of these devices. The adhesive, we have experience with the adhere, not with the contact forte, and we have right now in press a paper that shows with patients with children with atresia, and we compare the use of adhere with passive bone conduction devices. Well, basically, those were 16 children that had a passive transcutaneous device, one of those transmitting through the skin. They had this device for years, at least 1 year, and an average of 3 years of use of their device. We took them to the hospital, removed the passive and the sound processor, and we kept the sound processor and gave them an adhere for 1 week. And we did a quality of life and a quality of audiological results study. And to make a long story short, the results of this study show that the quality of life, the tolerance of the patients to the new adhesive device and the audiological study were similar with the adhesive and with the passive transcutaneous. Therefore, the question that I will bring now to your consideration is, if you have a child like this and need to make him hear better, will you use, if the results are the same, will you use a surgical or a non-surgical solution? And in my opinion, the time for the passive transcutaneous devices is coming to an end, because the active are every time more easy to put in children, and the results, the audiological results of the adhesive devices are quite the same as the one with passive transcutaneous. Now, percutaneous devices, Baja and Ponto, you all know these devices. They are in the market for a very long period of time. As you can see here in this picture, this patient had a Baja before. The Baja that we were putting at the beginning, we did a reduction of the skin, a large incision, a reduction of the skin just to make it thin. And it was a big surgery with not very good cosmetic results. And right now we are putting the Baja with just a punch hole and making the place for the screw that holds the abutment on top. So right now the surgery for Baja it's quite much more simple than it was before. Now, bone bridge. Bone bridge has 2 generations. Bone bridge arrived to the market back in 2012. So we have more than 10 years experience with bone bridge. The first bone bridge was the BCI 601. And the main problem with the BCI 601 is that it needed 9 millimeters of depth in the bone to be able to be inserted without exposing the dura. By the way, exposing the dura is not a big deal, it's not a problem. You all are otologists, and you know that the dura will be in your surgical field for the rest of your life. But if you can put the device without exposing the dura, of course, it will be better. And now the BCI 602 has only 4.5. It's about half of the size of the previous version, and this one very frequently does not need to expose the dura to be inserted. What we do is, well, coming back to the previous slide, we can put the bone bridge on the mastoid. We can put the bone bridge on the upper part of the mastoid. They call it the middle fossa, but talking about the middle fossa in the House Institute, it's a bit, in the House Foundation, it's a bit weird, because this is not a middle fossa. It's just a small hole in the bone of the upper part of the temporal bone. Or you can put it retrosigmoid, which again is not a retrosigmoid approach. It's just a small hole behind the sigmoid sinus, and we remove all the concerns about the retrosigmoid and the middle fossa, like otoneurosurgical procedures, and keep superior and posterior. Well, in our practice, bone bridge usually goes or posterior, retrosigmoid, or superior. Why? Because, as I mentioned before, we use bone bridge basically in radical cavities and in patients with atresia. In radical cavities, there's no mastoid. There's no way you can put the bone bridge in the mastoid. And in patients with atresia, there's a mastoid, but this mastoid may be used in the future if someone wants to reconstruct the pinna, and will put some screws or will manage that area. So in children with atresia, we also go posteriorly or superiorly. We just prepare the incision. This is a retrosigmoid position of the first version of the 601. We make a small incision with a flap raised in two different planes to cover, after the operation, the implant and avoid extrusions. And we make the hole for the implant. You may expose the dura or not, depending on the thickness of the bone. And we insert the device. You need to create a subperiosteal pocket, like for any other implant that we are going to deal with this morning. And this transition between the coil and the vibrator part, the FMT, is you can bend it, and you can put it on the best position for every single patient. And the good part of the new edition, this is the 602, which is much smaller. The best thing of the new edition, apart from the reduction of size, is that you can use self-drilling screws that fix the implant, very safe, very strong, and are much more easier to insert. Now, the second system is the active transcutaneous, the OSEA2, which is newer. It was developed before, but the use in clinical practice is for the last months, year and a half, and it's a bit bigger than the size is a bit larger than the bone bridge. And you do the same. You prepare the subperiosteal pocket, and after preparing the subperiosteal pocket, you put a screw like the screw of the Baja. Actually, it's the same manufacturer, and it's the same system of preparing the osea. Then you insert this is no, you cannot bend this transition, but you insert the device in the subperiosteal pocket, and you fix the osea with one single screw. And this is something that worries me a little bit. I mean, we have very short experience with the bone bridge, with the OSEA2. We have a long experience with the bone bridge, but with the OSEA2 we have just less than a year of experience. And having just one screw and having the whole thing moving over one screw, I'm a bit concerned about the movements that you do here in the area of the magnet, pulling and pushing with the magnet. They are going to be transmitted only to a one fixed point, and I'm not sure whether this is going to create problems in the future, but right now the results are very good. Now, what are the results of these bone conduction devices? Results for bone conduction devices depend on two main factors. Number one is the bone conduction threshold. It depends on how low your bone conduction will be. The results will be better for good bone conduction and will be a little bit worse for not so good bone conduction. And it depends, obviously, on the type of device. And to make it simple and a bit schematic, if you use percutaneous baja and ponto or active transcutaneous OCA2 and bone bridge, you can make the air-bone gap close even in mixed hearing losses. So the bone conduction, even being low, you can make a good closure of the air-bone gap. If you are using adhesive or passive transcutaneous, as I mentioned before, then you can close the air-bone gap only in purely conductive hearing loss. And as you saw before, the indications, the thresholds of every single device overlaps to the other ones. Okay, now let's move to active middle ear implants. And this is a very interesting field. Active middle ear implants were traditionally classified as piezoelectric versus electromagnetic, or partially implantable versus fully implantable. By the way, we all want fully implantable devices. We all want to have everything inside. But for fully implantable devices, we have two main problems. Number one is the microphone. If the microphone goes inside of the body, like for a fully implantable device, your microphone, if you scratch your head, your microphone will bring you the sensation of being in the middle of a thunderstorm. When you eat, you will hear the sound made by the muscles and the joints during mastication. And the second main problem is that you need to charge this device, and you need to have your head close to or near the system that charges the battery of the device. And the fact is that right now, even though we still work, some people are still working on fully implantable devices, they are not very good in clinical practice, as you will see in a minute. And the last classification that I use, and is the one that I use more often, is alive versus dead. Why? Why? Look at this. You have here 6 different active middle ear implants. Out of these 6 active middle ear implants, 4 are no longer available. We had the Carina until very recently. It was fully implantable, and it was also you could also have it as partially implantable. But the problem is that the fully implantable was giving problems, and it was not possible to keep it in the market, so they disappeared. And right now we only have 2 systems that are still, as I say, alive, which are STEAM and Vibrant Sound Bridge. STEAM is made by an American company. I don't know if you have any experience on the STEAM. We don't have any experience with the STEAM. And to me, STEAM has a very serious consideration. When you use a STEAM, you use the eardrum as the microphone to avoid the complications that I mentioned before. And with the information received by a sensor on the eardrum, you can create the movement of the ossicular chain. But for this to be able to make, you need to disconnect the eardrum, the tympanic membrane, from the stapes. So you need to disconnect the ossicular chain. And personally, I don't like to add a conductive hearing loss to the sensory neural or mixed hearing loss that the patient already has. So we have no experience with the STEAM, and we only have experience with the Vibrant Sound Bridge. Let me tell you a short story about the Vibrant Sound Bridge, because I was involved in the development of the first version of the Vibrant Sound Bridge, which was called Symphonics, and it appeared in the 90s. We started using Symphonics at the beginning for sensory neural hearing loss. It was a system that was fixed to the long process of the incus, long process of the incus, and it was designed for sensory neural hearing loss patients with an air conduction within the red shadow area that you have here. But the fact is that a bit more than 10 years after the development of symphonics, Medel bought the company, Symphonics, and renamed the device as Vibrant Soundbridge, and started to consider that it could be also used for mixed and conductive hearing loss. In fact, Vittorio Coletti, an Italian surgeon, in 2006, proposed something that was called the round window vibroplasty. The round window vibroplasty, as you can see here, is to put the vibrating part of the device, the one that is called the FMT, floating mass transducer. You put this vibrating part in contact with the round window. There was a concept developed by or popularized by a Spanish otologist, a very famous otologist in Spain, Luis Garcia Ibáñez, the father of three generations of ENT doctors. And Luis Garcia Ibáñez proposed the idea or the concept of sound inversion. Sound inversion was sending the sound from the round to the oval window instead of sending it from the oval window to the round window like we do in physiological hearing. And taking this concept of making the round window vibrate and sending the sound to the oval window, he proposed to use the FMT in contact with the round window and to use the Vibrant Soundbridge not only as Symphonics was designed for sensorineural hearing loss, but also for mixed and conductive hearing loss. And from that moment on, the indications of Soundbridge expanded, and the design of systems to put the FMT in close contact with the structure that you want to vibrate was expanding also. So they created couplers for the round window, for the short process of the incus, for the long process of the incus, for the incus itself, a lot of different ways to couple the FMT to the hearing structure that we need to perform. We have used with frequency the round window vibroplasty in patients with radical cavities, patients undergoing 3, 4, 5 more surgeries, still draining the ear, still and every time more having a mixed or a conductive hearing loss, for whom you don't want to use more conventional surgery. More radical cavities are not the solution. And for those patients, it's a small number of patients, but for those patients, the Soundbridge in the round window is great. Here, I will show you a round window Vibrant Soundbridge with subtotal petrosectomy in one of these patients, still draining ear, several operations, no cholesteatoma, of course. You remove the whole mucosa and skin, and this is the left here, middle fossa, the facial nerve is here, and the oval window is here with some remnants of the stapes, and the round window is here. With the dummy, you check the size of the FMT. We usually, and this is the main problem of Soundbridge, you usually have to drill the edges of the round window niche just to make the FMT able to connect directly or with a coupler to the round window membrane. And this is the worst part of the operation because this is dangerous, but if you do it carefully, you can do it. And then you fix the device. I mean, here the screws are just to fix the device, are not transmitting. And we put the FMT in contact with the round window. We close eustachian tube because we are going to fill the cavity with fat doing the subtotal petrosectomy. And with this, we'll solve the draining ear and we'll solve the hearing loss. We put the FMT in contact with the round window after making the hole enough to, you see, the window movement by pressing the stapes, the remnant of the stapes. We remove part of the fibrous tissue, and now you will see how by touching the stapes, you will see how the FMT will move. it moves, it is transmitting the sound. Now we put a piece of cartilage on the back to make all vibration go inside. And this device for this subset of patients is working very well. Again, there are not many patients. We always fill the cavity, like for acoustic schwannoma, we'll fill the cavity with fat and we finish. You also can use the stapes coupler or the previous clip to fix the FMT to the stapes head when you have a good stapes available. And this is also a very good system of transmission. And you can use the short process of the incus by exposing the incus. And to me, this is a much, much better approach to sensorineural hearing loss than the long process of the incus, because here you only have to make an athecotomy, you expose the stapes and put the FMT directly on the strongest part of the ossicular chain, not at the incudostapedial joint, which is very weak, and you have to go through a posterior tympanotomy approach. I mean, you can do a posterior tympanotomy approach, of course, we are all otologists, but if you can make an approach to the short process of the incus, the results will be as good as with the long process of the incus, and the risks for the patient are much lesser. Now, results for vibral sound bridge in sensorineural hearing loss, you see that functional gain is usually very good. This is a paper published in 2016, I think, or something like that. In mixed and sensorineural hearing loss, both hearing losses, in a paper that we published, Luis Jaleta was part of this paper. You can see that the results are also very good. The round window coupler and the short process of the incus coupler are working very well, and they provide a very, very good average functional gain. And for purely conductive hearing loss, in this paper by Mario Cernotti, in purely conductive hearing loss, the result is also very good. Now, if the results are so good, why these devices, why active middle ear implants are not more popular among the otologists? Well, basically because they are difficult and there is a risk of hearing deterioration. As you saw before, if you drill the round window niche to put an FMT there, you risk opening the internal, the inner ear, and that will be a serious problem for this patient. When you do that for a cochlear implant, sooner or later you will have to open the round window, but here you cannot open the round window, and the risk for manipulating the ossicular chain in patients with a sensorineural hearing loss, I think this is the main reason for not making these devices very popular. But again, they work very well in experienced hands on selected patients. Okay, let's move to the third of our devices, the cochlear implants. I'm not going to tell you many things about a cochlear implant. We are in the house of cochlear implants, so nothing special we can say for cochlear implants. The indications, the conventional indications, when I started in 1990 using cochlear implants, they were only for bilaterally deaf patients or with some years of experience for patients with no benefit from hearing aid or any other implant. But right now, this is not the situation with cochlear implants. Right now, we have emerging indications for cochlear implants that I will try to shortly summarize to let you know how different is the situation of cochlear implants over the last 30 years, from purely deaf, bilaterally deaf people to single-sided deafness. Single-sided deafness even in children. Single-sided deafness in children. Of course, if you have a child that is congenitally deaf from one side, and the parents want to have a cochlear implant for this patient, and everyone will understand that this patient that will be a normal child if we don't put anything. Of course, if you make serious scientific studies, the development of language and hearing will be better with bilateral hearing. But if you don't put anything, it will not be a horrible situation. So if the duration of the hearing loss is very long, or the patient comes to you much after the onset of the hearing loss, then the indication for single-sided deafness in children will make in real practice a very low number of patients. And for those patients, you have to be very careful and consider that you are making a sick child from a normal children. So this is something to be considered. I'm not saying you shouldn't use it. We use, but we use with extreme care. And with adults, it's basically a patient decision. We do a lot of acoustic tumor removal surgery, and we use basically the translab approach, and we create a single-sided deafness patient every week, more or less. And less than 10% of these patients want something for hearing rehabilitation after becoming single-sided deafness. If patients want, and if they have tinnitus may be something that can support the indication of a cochlear implant, even though it's not fully clear that tinnitus will disappear after a cochlear implant, but it may help in the decision. A step forward will be the use of cochlear implants in asymmetric hearing loss and it's called bimodal stimulation, which basically is a patient with one ear that can still use a hearing aid and the other ear in which you put a cochlear implant. Will they get binaural hearing? Well, they will have bilateral hearing, but not all of them will be able to develop a complete binaural hearing. So this is something that it must be considered. And the fact is that these patients will have improved language discrimination. And nowadays it's a more common indication than single-sided deafness. Electroacoustic stimulation is another situation in which you have a patient with very good low tones and lost high tones. And for these patients, you can still use a hearing aid on the same ear as the cochlear implant, hearing aid for the low tones, cochlear implant for the high tones. And for these patients, and for all patients with cochlear implants, it is extremely important to remember that you have to preserve not only hearing, like in these patients, but you have to preserve structures. Because the child that you will, after this lecture, put a cochlear implant, will probably need 2 or 3 more cochlear implants in the future, and let's know what happens in 60 years. So the more structures you preserve in the inner ear, the more chances this patient will have to use future technology. During the recent pandemic, we decided, the Spanish Society of ENT decided that there was only one emergency procedure for otologists, and that was, it was the pandemic, even cancer were not undergoing surgery. That was a horrible situation, you all know, because you lived the situation like we did. And in patients with meningitis, especially children with meningitis and bilateral deafness, cochlear implant was considered an emergency procedure because you have a high chance of fibrosis and ossification in a matter of weeks, fast. And if this happens, you are not going to be able to insert a cochlear implant, the electrode of a cochlear implant. With cochlear malformations, we have a similar situations. We have a high risk of gusher. Remember, the facial nerve may not be in the normal place, and you have to choose the electrode array and the approach concerning according to the type of malformation. And even for some of these patients, as we will see later on, you may even consider the usefulness or the need to move to an ABI instead of a cochlear implant, and we will discuss this in a minute. The surgical technique of cochlear implants is very easy, except when it's not easy, and then it's a real mess. but it is usually a straightforward procedure with a mastectomy. You do a posterior tympanotomy, expose the round window. I think that today most cochlear implants are performed through the round window just to preserve structures. We use steroids. We open very carefully the round window, no suction at all, please, and very slow insertion of the electrode. There are other approaches which are possible, but they are seldom used. And right now, the endoscopic and the robotic approaches are very popular, and they are being developed. And we don't use them in clinical practice, but maybe they are the future. I cannot be sure whether it will be the future or not. This is the opening of the round window on a right side ear, and here you have the slow insertion of the electrode that must be very carefully inserted into the cochlea. Well, just a few words about the surgical technique in special situations like vestibular schwannoma and radical cavities. For these patients, we usually perform a subtotal petrosectomy. As I mentioned before, we remove all the skin and mucosa and insert. This is an example of a malformation. This is the stapes. This is the facial nerve in between the stapes and the round window. And for this kind of patients, we do a radical mastectomy approach. We open the cochlea. There's no round window. This is a serious malformation. We insert a short electrode. And for these patients, we do a subtotal petrosectomy, close the ear canal, and give them the chance to hear with the cochlear implant. And to finish with my presentation, just a couple of words about ABIs. And just a couple of words because you are the fathers of ABIs there. They were developed by House and Hisselberger in 1979. There are some situations when ABI is the only option, patients with NF2 and nerve section, and children without cochlea. There are situations when ABI may be an alternative to CI, and we have to consider this option. And those are the patients with NF2 preserving the cochlear nerve, and we use this test electrode that we design along with the Medel company to check the functioning of an intact cochlear nerve at the end of tumor removal. And we do this because the worst cochlear implant in an FF2 patient in our hands works better than the best ABI. So CI's cochlear implants in vestibular schwannoma are not as good as cochlear implants in normal patients, but are better than most ABIs. Our experience with ABIs in NF2 is not very good. Now in children, we have what I call the gray zone. The gray zone is the situations where you cannot be sure whether there is a nerve or not. Bilateral cochlear nerve deficiency, even if you don't see the nerve, some fibers of the nerve may be there and maybe a cochlear implant works. Bilateral severe malformation, we mentioned that before. If a cochlear ossification is massive, then you may think about the option of an ABI. And for all these situations, the key is time. If you have time to put a cochlear implant and see if it works, this is what we do. We put a cochlear implant. If you don't have time because the child arrives when it's 3 or 4 years of age, you see the child at that time, and you are pretty sure that there is no cochlear nerve or there's a horrible malformation or a massive ossification, then the option of an ABI may be a very good option. In these childs, you will notice, as you will see here, that there is only one nerve going to the internal auditory canal, which is the facial nerve. There's no cochlear nerve. We have to look at the choroid plexus, try to find the lateral recess through the foramen of Glushka, and insert the ABI. And the results in children, at least in our experience, are much better than the results of ABI in adults, in NF2 patients, which don't have very good results. In general, the results of ABI are very variable. The hearing sensation, you can get it in 80% of the patient. It's a good aid for lip reading, but it's not like a cochlear implant. And patients being able to understand without lip reading are just a small percentage of the patient with ABI, and you will get non-hearing sensations in a very large number of patients. So to summarize, we have been going from the adhesive bone conductions or the hearing aids to the extreme end of the spectrum, which is the ABI. And the fact is that patients don't come to you and tell you, doctor, can you put me an ABI? They come with a hearing loss. And when we are facing a bilateral sensorineural hearing loss, we start thinking about hearing aid, a middle ear implant, if not a cochlear implant, and if not an ABI. When you have a single-sided deafness, as I mentioned before, you can use a cross system, you can use a bone conduction device, you can use a cochlear implant, or for some patients, you can use nothing, which is sometimes the best option for a given patient. And finally, for conductive and mixed hearing loss, we go for conventional surgery and hearing aids at the beginning. If they don't work or you cannot use it, we move to bone conduction, active middle ear implants as the last option. Now, to summarize, and I hope you got a good idea of what's the situation right now for hearing restoration. We have from hearing aids to ABI a real world of different options. And please, the younger people here, don't forget the classic options, hearing aids and conventional surgery, and try to be able to look into the ear of your patient and into the conditions of every single patient and try to find the most appropriate solution for each patient. And with this, I want to thank you for giving me your attention and the chance of being with you this morning. It's been a real pleasure for me. Thank you very much.